Good afternoon, everyone. My name is Shalina Sajwani, and I am doing my genomics presentation on hemophilia. I wanted to go ahead and start with a few famous people in history who have been rumored to have had hemophilia. Top left, I have a picture here of Genghis Khan, who was a famous conqueror and emperor. Bottom left, Mother Teresa. She was also rumored to have had hemophilia. Top right, Abraham Lincoln was also rumored to have had hemophilia. And bottom right, we have Queen Victoria. And it was said that she passed it on through generations and generations, and it was oftentimes called the royal disease because of that. So what is hemophilia? Hemophilia occurs as a result of a mutated gene, and it gives us a factor deficiency of either factor 8, factor 9, or factor 11, which are all clotting factors. And because we have a deficiency in those, it causes an inability to clot and prolonged bleeding. So I made a table here for you guys so that we can compare and look at the differences between the three different types of hemophilia. Hemophilia A and B are the most commonly related in the fact that they are both X-linked recessive disorders. They affect male children of female carriers. Hemophilia A is a factor 8 deficiency and hemophilia B is a factor 9 deficiency. Hemophilia A is the most common. It occurs in 1 in every 5,000 males, and 2/3 of those who have the disease have the severe form of the disease. Hemophilia B occurs 1 in every 30,000 male births, and half of those who have the disease have the severe form. Hemophilia C, it's a little different from hemophilia A and B in the sense that it is autosomal recessive. It also affects both sexes equally, so it's not as discriminatory towards men as the first two. It is a factor 11 deficiency, and it occurs in 1 in every 100,000 male births. And the one really important thing about hemophilia C is that it's very unpredictable. Even those who may have the severe form of the disease may not bleed as excessively as those who have the milder form of the disease. So it can be very difficult to manage. And these are the patients that you definitely 100% want to send to a hematologist to have them have baseline studies done and really understand what their clotting factors are at. Because it can be very difficult to manage their disease process because of this unpredictability. Inheritance pattern. So females are carriers and may have some clotting defects, but they will be very mild compared to the male counterparts who cannot be carriers. They either have the disease or they don't. Males who receive the X-linked disease will have the full-blown hemophilia, and they will exhibit the signs and symptoms of the disease. So like we said, men cannot be carriers, but females can be. And a female carrier may have some clotting issues, but they will always be mild compared to the male counterparts. So signs, symptoms, and severity. So because hemophilia is a clotting factor deficiency, we are going to see a lot of bleeding happening as far as the signs and symptoms. So you're going to see some easy bruising in these patients, inadequate clotting of mild injuries. So they might have delayed clotting after a trauma, continuous oozing for days and weeks, things like that. Spontaneous hemorrhage is also common. And one of the most common sites of spontaneous hemorrhage is a joint, which is called hemarthrosis. And I included a picture here so we can see how there's kind of that swelling to the side of the joint where all that blood is starting to collect. And these patients will have decreased range of motion to the joint. They'll have pain, swelling, redness. And in children, ankles are the most commonly affected site. In adolescents and adults, it's the knees, elbows, and ankles that are the most commonly affected site. And once a joint has been subjected to the hemarthrosis, the likelihood of it happening again goes up significantly. Bleeding into muscles is also common, like if you were to have a quadricep or the iliopsoas muscle, just bleeding into that muscle group can cause compartment syndrome, and so that's another complication we have to watch out for. One of the first signs and symptoms that you might see in a hemophiliac is post-circumcision bleeding. So these boys go into the nursery, they have a circumcision, and then all of a sudden you can't seem to stop the bleeding in these patients. And that should be a huge red flag to start testing for clotting factors and deficiencies. And usually that's the first signs and symptoms that the patient will have before they get diagnosed. These patients might also have spontaneous hemorrhage in their bladders. So you might get hematuria, GI bleeding, vomit or stool may have blood in it. Even intracranial hemorrhage can occur. So severity of the disease, you can have a mild, moderate, or severe form of hemophilia. And when you check the blood for the factor activity level, if they have 5 to 40% of the normal factor activity level, they are said to have a mild form of the disease. 1 to 5% of the normal factor activity level is considered to have a moderate form of the disease, and less than 1% is a severe form. Imaging studies are oftentimes done to evaluate the exact location and the extent of the bleed. So you might do an ultrasound over a joint area or a CT scan of the abdomen to see how much they're bleeding into their abdominal cavity. MRIs might be done to evaluate the extent of the bleed. So these are all common imaging studies that might be done. So let's say you have a patient who comes in and who is having continuous bleeding. You're probably going to want to do some baseline lab tests. So you're going to do a CBC, PT, PTT. CBC, your H&H might be low, or if they haven't been bleeding for a while, it might be normal. Your platelets will be normal because these are clotting factor deficiencies, so your platelets are not involved. Your PT, that tests factors 1, 2, 5, 7, and 10, which none are affected in hemophiliacs. So those will all be normal. So your PT will then be normal. Your activated PTT might be prolonged, and that's because the activated PTT tests factors 8, 9, 11, and 12. And 8, 9, and 11 are the ones that hemophiliacs have the deficiency in. However, it's important to remember that if they have the mild form of the disease, the APTT might also be normal. And so that's something to keep in mind, that if they have the mild form, it might not show up. But if it is prolonged, then that's a really big red flag for you. So those were your baseline tests. Now you want to dig a little deeper. You're going to do a factor 8 assay, a factor 9 assay, and a factor 11 assay. And I've put the normals on the right side right there. So we said earlier that we're going to categorize them as mild, moderate, or severe. So let's say we have a patient who comes in and has 4% of normal factor 8 activity. 4% would put them in the moderate range, and of normal factor activity 8 would put them as a hemophilia A patient. So you would say they have moderate hemophilia A. So now that you have diagnosed your patient with hemophilia, how do you treat it? So treatment is gold standard is replacement therapy. In hemophilia A patients, they can do infusions of the synthetic factor 8, which is known as octocog alpha. And if they're doing that prophylactically, it's recommended that they do it every 48 hours. Hemophilia B patients will do infusions of non-ACOG alpha, which is synthetic factor 9. And it's recommended that they do that twice weekly. If they're receiving the human form of the factor, they would have to go to an infusion center to receive that. But if they're doing the synthetic factor, they can reconstitute that at home and give it to themselves over like a 15-minute time period. Hemophilia C, like we said, doesn't follow the same patterns as the first two. So, of course, this would be a little different. There's no prophylactic therapy required for hemophiliac C patients. They only do on-demand therapy. And on-demand therapy is less expensive than preventative therapy. It basically is just you're doing replacement of the factor to stop bleeding when it occurs. You can also do it before a procedure, like if they're having a tooth extraction, you might have them do on-demand therapy then. However, there is a risk that bleeding will cause damage before the patient receives the demand therapy. So if there is a trauma to the patient, they might not get the demand therapy in time and the bleeding might cause some damage. There are complications that we need to be aware of. 20 to 30% of hemophilia A and 2 to 5% of hemophilia B patients develop antibodies or inhibitors, which destroy the infused clotting factors. So not only are they deficient in the clotting factors, but now when we're trying to replace them, they're developing antibodies against it. And the way we treat that is daily injections of the clotting factor so that the immune system begins to kind of recognize them and stop producing these inhibitors against them. Prevention. So number one prevention is to be prepared. So before a child is born, let's say the mother knows that she is a carrier of hemophilia or the father has hemophilia, testing the mother and the father before childbirth. Also, there's been a lot of controversy over whether vaginal birth or C-section is preferred for a hemophiliac patient, but whether or not you prefer one versus the other, everyone really agrees on the fact that forceps and vacuum delivery should not be used for boys that are being born with known hemophilia, because that can cause the intracranial hemorrhage and a lot more complications during the birthing process. At birth, we test the cord blood for clotting proteins, and then we do test them again at the 6-month range to confirm the diagnosis. I'm sorry, at the 6-month mark to confirm the diagnosis. Some factors do take time to develop, so it's important to check them again at the 6-month mark and make sure that we've got that definitive diagnosis. These patients should always receive vitamin K shots after birth and all of their other vaccines. We would just have to be careful of any bleeding into a muscle group or anything like that. And so watch out for prolonged bleeding time with vaccines, but they should receive all normal vaccines in childhood. Another thing we can do as far as prevention goes is just being aware of more common populations that hemophilia tends to affect. Hemophilia C tends to be more common in the Iraqi, Jewish, European descent. And it has been said that 43% of the world's hemophilia population lives in India, Bangladesh, Indonesia, and China. So if you have patients from these countries asking a really good detailed family history or genetic history, may be definitely worthwhile. And like I said earlier, preventing those injuries, shoulder pads, safety gear, and rapid treatment of acute bleeds. A few resources for education for your patients that I wanted to include. The World Federation of Hemophilia is a great website that patients can go to. It helps find treatment centers near them if they need infusions. The National Hemophilia Foundation also is a great website. They do a lot of research that helps set guidelines for treatment and management for hemophilia, helps providers with that. And some of their guidelines have been accepted into the National Guideline Clearinghouse as well. So they do a lot of qualitative studies, systematic reviews, if you want to go over those. As always, the CDC is my favorite website to go to for any type of information. But I did want to include this hyperlink for a web-based course that they're offering on hemophilia. It's about an hour long and it discusses treatments for our patients and also barriers that get in their way of receiving treatment. Things that we may not think about and not realize that can really help us optimize their patient outcomes and help us really optimize their health overall. As always, finding a local hematologist is awesome, and finding someone who is well versed in hematology will always help you have a good resource to go to. These are my references, and I hope you guys learned something about hemophilia today, and I appreciate your attention.